something in. Good. All right. Well, thanks everybody for joining us. We'll be, let's see, are there any non-UCT people there? It seems to be. So for those of you that don't know me, I'm Anria Horn. I'm a pediatric orthopedic surgeon at Red Cross Hospital. So tonight's talk is going to be on clubfoot and other deformities. It is, unfortunately, it's actually quite a large topic, and when I went through my talk again tonight, I realized probably need to split it up just because clubfoot is such a massive subject on its own. But we will soldier through, and I certainly don't want to be here until later than 9:30 either. So let's get going. Okay. Right. So we're going to start with clubfoot. And the other word for clubfoot that we often use is CTEV, or congenital talipes equinovarus. And very often people merely refer to it as talipes. So it's all the same thing, basically. And this is a very consistent typical deformity that consists of 4 elements. And I know for the more senior guys, this is all like old hat, but there's some juniors in the room, so let's look at that again. So we have 4 deformities. We have cavus, affecting the midfoot, adductus of the forefoot, varus of the hindfoot, and equinus of the hindfoot. And those are your consistent deformities in the clubfoot. What clubfoot is not is a postural clubfoot. So those are feet that are fully correctable, that may be in its resting position, be in a position that looks like clubfoot, but is fully correctable at birth. That's not clubfoot, and that does not require treatment. And then also metatarsus adductus. So we'll speak about metatarsus adductus later on, but usually it does not require treatment unless it is quite severe. So a little bit of history, just for fun. Hippocrates, back in the day, 400 before Christ, already identified 3 key principles in the management of clubfoot, which we still adhere to. And that is, firstly, to start manipulation as soon after birth as possible. Secondly, that most feet can be corrected by gentle manipulation, so no extreme force is required, and that in order to achieve and maintain the correction, you need to overcorrect it firstly, and then keep it in that overcorrected position for an extended period. But unfortunately, a lot of Hippocrates' wisdom and knowledge got lost over the years. And then fast forward 2,200 years, or in 1800s, and they had this sort of like brutal medieval device called scarpa-shoe, which they used to correct club feet. And as you can see, that it doesn't really address all the components of the deformity as we know. So you can see, I mean, it's merely going from varus to valgus. And then Robert Jones, famous as he is, was using this sort of also quite brutal device of Thomas Wrench to correct club feet, which again is not really in keeping with the principles that we use. So surgery for clubfoot only started happening much later. So the first successful Achilles tenotomy was performed in 1830. Plaster of Paris was first used for the manipulations later in 1830, and then major corrective surgery was really only performed at the end of the 19th century towards the beginning of the 20th century. And then the first tibialis anterior transfer was performed by Dunn in 1922. As far as manipulation is concerned, because that's really, I mean, the sort of the crux of treatment for clubfoot, is prior to Ponseti being around, Kite was the most prominent advocate of serial casting for club feet, and this was in the early 20th century, so before 1950. However, he required multiple casts to correct the hindfoot varus, and would often fail. And it turns out that the error was that he placed the fulcrum of the correction, other than what Ponseti does, he placed it at the calcaneocuboid joint. And it has subsequently been dubbed Kite's error. And when you talk to people about clubfoot in their conversations and so on, it's always discussed. You know, when you talk about why manipulation doesn't work. So merely moving your finger 5 centimeters, not even 5 centimeters, 1 centimeter more proximal, you would have had the correct fulcrum, and you would have corrected the clubfoot. Anyway, going back a little bit to etiology, there are several theories as to why clubfoot develops. There is the molding theory, the neuromuscular theory, and the maturation disorder theory. So the molding theory postulates that there's decreased fetal movement or space in utero, and this is all your typical small uterus or limited space conditions, so prim gravida, etc. And this causes postural positional clubfoot. But unfortunately, that does not explain the anatomical and histological abnormalities we see in clubfoot, so that theory has been scrapped. Then the neuromuscular theory postulates that there's abnormalities of innervation and delayed spinal development. So we know that clubfoot is associated with several neuromuscular conditions, such as spina bifida, polio, arthrogryposis, tethered cord, etc. And it's also been known to be associated with the delayed closure of the L5 segment, or spina bifida occulta, you see in this patient. And muscle type, as we know, is a function of innervation. So there does appear to be some neurological aspect to the development of clubfoot. Then the other theory, which is maturation disorder, states that a fetal foot looks like a clubfoot at 8 to 10 weeks of development, and that potentially arrested development might lead to the clinical picture of clubfoot. But this, unfortunately, again, doesn't explain all the histological features. So we know there's a large genetic component to this, and there's currently a study going on at our clubfoot clinic as well as Tigerberg's, where blood samples are being taken from all idiopathic clubfeet to do genetic typing in an attempt to identify the genes responsible. So some genes have been, or I think one gene has been identified that's present in all families with clubfeet, but it's not like a single gene, like in neurofibromatosis or anything like that. It's more complex than that. But there's concordance between twins. Certain populations are more prone to it. So it's polygenetic, and it seems to be non-sex linked because clubfoot appears to occur equally in males and females. The pathanatomy is important to understand when you're trying to correct the clubfoot, and also when you later on in a neglected or a recurrent clubfoot, you perform surgery. So the talus is underdeveloped from the word go. There's medial and plantar deviation of the talar neck, and there's disorganized vascular channels, delayed ossification, and a small eccentric ossification center. So the whole talus is actually abnormal. Then there's medial subluxation of the navicular with contraction of the spring ligament, as well as anterior tibial artery hyperplasia, and or even aplasia, and in quite a large proportion of patients with clubfoot. The tibial anterior artery is gone; it's just not there. And it's actually useful to think about clubfoot as a whole sort of limb deficiency, and one should almost place it in the same category as your fibulae mammaelias and your tibial aplasias, because it doesn't just affect the foot. I mean, if you've seen enough clubfoot patients, you'll see that their limbs are short, but a short leg, a small foot, and they also have atrophic muscles on the affected side, even though they have a beautiful correction of your clubfoot. So there's a total limb deficiency, and clubfoot should be seen as that, as opposed to an isolated foot abnormality. Yes, there's some pictures. This is from a cadaver, obviously. No, we just cut the talus out. No, it's from a cadaver species, cadaver specimen in the unilateral clubfoot. You can see how much smaller and sort of atrophic the talus is on the affected side. And these are slices showing us the vascular channels, as well as, remember when I said, it's got this sort of like eccentric ossification center there, and quite disorganized vascular channels compared to the normal side, where it all it's nice and lined compared to that side. So that's what's happening there. So if you think about the clubfoot foot, the abnormal relationships in the clubfoot, this you'll appreciate clinically and radiologically, is that the whole foot is displaced medially under the talus. So the talus is like roughly in the right position, but then the whole foot is like medial behind it. The calcaneus, the naviculars, navicular cuneiforms, cuboid, everything. Calcaneus medially rotated. Anterior process of calcaneus is under the talar head, and I'm going to show you some nice pictures to demonstrate that now. cuboid's medial, cuneiforms are medial. The forefoot is pronated, and that's what leads to the cavus deformity. So it's turning in like this as pronated. That's why the first step is supination. We'll get there now. And the first ray is plantar flexor. And here's just the bone, sawbone models showing that severe abnormal relationship of all the tarsal bones to the talus and the calcaneus respectively. And this X-ray demonstrates it well. So if you take an AP X-ray of a foot, be it an adult or a child, there's usually divergence of the talus and the calcaneus, like you can see in this X-ray. And the normal angle there is between 15 and 30 degrees in a child. But in clubfoot, because the talus is rotated, the calcaneus is rotated under the talus, they're now parallel, they're now overlapping. And you can see that talocalcaneal angle is significantly decreased. And back in the day, people used X-rays quite a lot in the treatment and diagnosis of clubfoot, whereas now we don't. It's largely clinical. But then these angles were always measured to sort of like document how severe the clubfoot is. But this obviously preceded the Pirani score and the other ways we use it now. But that's just interesting to understand the pathology that you're dealing with. And the same thing happens on the lateral. So on the lateral, again, we've got a talocalcaneal angle of 25 to 35 in a normal foot. And then in the clubfoot, they're parallel. So those are just interesting little X-ray features of clubfoot, because we don't take X-rays of clubfoot anymore, so we don't know. Okay, then the histology is interesting as well. So what you see is there's a fibrous mass at the site of the tip post insertion. And just actually going back to this X-ray, because this demonstrates it quite well, it's all happening here. So that area there is the contracted mess. It's a spring ligament, it's the post insertion, it's the talonavicular joint capsule. So it's what's the other thing? The where FHL and FDL cross, the knot of Henry. So all of that is like all contracted and fibrous and severely abnormal. And if you take that tissue, it actually contains quite a lot of myofibroblasts, which is the same cells that you would find in Diptros contractures. And there's this organized collagen orientation. And then in addition to this, there's also a contraction of the peroneal sheath and the calcaneofibular ligament, which is the posterior lateral tether. And it's important again to know about this, because you need to address that when you do surgery for them. And here's just some histological slides. I can't read histology, but you can clearly see this looks organized and this looks disorganized. So this is a disorganized clubfoot spring ligament in a 16-week-old fetus, as opposed to what a normal ligament should look like. So there's a inherent basic abnormality there. And that's why I'm not sure about that whole neuromuscular theory and so on. I really do think that this is an isolated condition of the foot. Anyway, how do we classify clubfoot, and why do we classify clubfoot? So classification is mostly used for prognostication, for monitoring of your success of treatment, especially the Pirani score. And there's different ways of classifying it. So there's etiological. So we know we've got idiopathic, syndromic, and neurological clubfoot, and they behave differently. And that's why it's important to distinguish between them. And then the severity, there's the Maglio score and the Pirani score. And here's just a little list of all the conditions that you can expect to see, all the genetic conditions that you can expect to see a clubfoot in. It's in the book. Look. So this is the Maglio classification. I'm not going to spend much time on this because we don't use it. I don't think anybody uses it except the Maglio and his team. I think he's Italian. But it's a little bit more complex in terms of grading it. You need a goniometer so that you can measure it accurately. Well, I suppose you can just eyeball it, but accuracy would depend, obviously, on accurate measures. So it's got good inter-observer reliability, but you require training and special equipment and so forth, and it's a little bit cumbersome, so we don't use that. We just know about its existence. Then the Pirani classification we do use, and I'm sure everybody here uses it. And it's quite simple. We look at 6 features of the clubfoot. There's a hindfoot score, and there's a midfoot score. And you can score it from 0, 0.5 to 1. And this picture clearly illustrates what you're looking for. So just to recap, the hindfoot scores is the medial of the posterior crease, the empty heel, and the rigid equinus. Yeah? And there's your posterior crease. You can see what we consider normal and what we consider not normal. It's probably not the best examples, but anyway, that's what it is. And then the heel, easily palpable, palpable in depth, not palpable. There's somebody once said you have to do this thing. So if your forehead would be a 0, because you can feel the bone, in your nose, you have to push harder to feel the bone, and then your chin, you can't feel the bone. Something like that. I don't know. It doesn't really work. But if you do enough feet, then you'll probably get a feel for it. So there's all your things. So your maximum achievable score here is 6. The normal foot is 0. So it's simple and 100% inter-observer, almost 100% inter-observer reliability, and it's used most commonly with the Ponseti score. So for those of you who are not from UCT, I'm sure you guys also have clubfoot clinics where steps is involved, and they've got those little sheets that you fill in every day or every time you do the cast where you put the Brownie score and so on. So you should all be quite well versed in the use of it. So it monitors the progress during a Ponseti treatment, and if there's no progress, something's wrong. So your Brownie score should decrease every time you apply the cast. It's a little bit, I always say this, it's like the partograph. If you don't move, if you don't progress, then you're crossing the line somewhere and something's wrong, you have to change something. Okay, so obviously this isn't life or death, but it is still a child's foot and it's the child's mobility. So it is important. If you're sitting at the same Brownie score week after week, something's wrong. So what's the most common thing that's wrong is you're doing it wrong. So poor technique is a very common mistake. And I think what happens, unfortunately, is we have a lot of inexperienced people doing the cast unsupervised because everybody thinks, oh, it's just a cast, it's easy. And that's unfortunately also something that happens is if something's common and it looks easy, it's done poorly because nobody makes an effort to become really good at it because they think it's easy. Anyway, first thing. Then otherwise, you may have tried to start correcting a deformity before properly correcting the previous one. The greatest example of this is if when you're trying to start to dorsiflex the foot when you haven't had enough AB adduction. You must abduct the foot to 60%. We'll get back to that. It also might mean there's a need for surgical intervention. So sometimes when this happens, it's worth taking an X-ray and seeing, there might be a tarsal coalition. There might be something unexpected on the X-ray. Of course, once you've addressed all your previous potential troubleshooting points, such as bad technique and incomplete correction. And then in your complex and syndromic feet, unfortunately, they are just extremely difficult to correct. So very often that just happens. And then it might be necessary to further examine the patient, make sure you're not missing something like a spina bifida that you may have missed, or a tethered cord, or a syringomyelia, or who knows, but there might be something else there. So there's the Ponseti, and the wonderful thing about Ponseti and why his treatment has revolutionized treatment is because he understood the deformity properly. So he dissected cadaver feet, trying to understand what the pathophysiology and the pathoanatomy is, and that's how he came up with his method. And it actually is revolutionary and incredible. And he came up with this like in the 60s, and it was only globally accepted, I think, in the 90s. And in our unit in Cape Town in the early 2000s, we started using the Ponseti method. So, yeah, always a little bit slow on the uptake. So the first cast you apply is to supinate the forefoot on the high foot. Then it looks like you're making the foot worse, but you have to align the forefoot to the high foot, and that way you address the cavus. And then you start gradually abducting the foot around the talonavicular joint. And this you can take your time with. It usually takes 4 or 5 casts, or not 3 to 4 casts basically. But do not try and address the equinus while you're doing this. You have to abduct the forefoot first. Then your fifth cast, then you start correcting your equinus. You see, I'm repeating myself here, but it's because it's important. And in my experience, almost all clubfoot require tenotomies. I would rather do a tenotomy than not do one. It works really well. It's minimally invasive. They heal. It's like, just do it. I mean, if there's any doubt, just do the tenotomy. And then you keep it in the maintenance course, and that's then followed by bracing, which is full time for the first 3 months, and then nights and naps until the age of 4. So that's what's been prescribed. But realistically, I don't know many patients that can persist with the bracing after the age of 3. It's just that the kids start taking it off themselves, and it becomes virtually impossible. So I always feel lucky if I can keep them in their braces till about 2.5, and then that's usually okay. So back to common errors that we do in Vanzetti. There's a failure to correct the pronation first. So you immediately start wanting to fix the whole foot, and you don't do that. Kite's error, which is when you put the thumb at the calcaneal cuboid joint, not at the talonavicular joint, and which means that you can't correct the hindfoot varus, and you'll never get a correction there. And then an attempt to correct the equinus prior to getting full abduction. So a nice way to think about degrees so that you can guess more accurately is look at a clock face. I know everybody now uses smartwatches. They probably don't know how to read a watch anymore, but quarter past would be 90 degrees. So 10 past is 60. And then you can sort of like get a mental image of how much 60 degrees is. Common complications of Vanzetti casting would be pressure sores, and often also in the neuromuscular feet because they're insensate. Midfoot break. So this is very common. Because if you look at this x-ray, for instance, if you ignore the bones, the foot looks plantigrade. You see there, the soft tissue shadow there shows you, oh, very nice. You've got such a nice correction of your dorsiflexion, but on the inside, showing the whole heel is still in equinus, and he's dorsiflexing through the midfoot. And this is because you didn't do a tenotomy. Don't do that. And then lastly, there's the flat top talus, which I think is less common than we think. But it's purported to be because of forced dorsiflexion. And again, failure to do a tenotomy if needed. Okay, then the bracing. There's some technical tips here. So like I said, full times for the first 3 months after you remove your cast, then nights and naps afterwards. The feet, when you set up your brace, the feet's shoulder width apart. The affected foot is externally rotated 60 to 70 degrees, and normal foot 30 to 40. Quite difficult to maintain compliance, and non-compliance is the biggest cause of recurrence. But in all our clinics, we have counselors and people talking to the parents, and we see them regularly and encourage them and threaten them with surgery and all kinds of things. So the compliance is okay, but it is something to be very mindful of. So recurrent clubfoot we see, and that's a big problem. So it can just happen. So there's no series, no article, no symposium that I've attended where recurrent clubfoot is not an issue. So we know it happens, and it's not always because somebody did something wrong, but it can be because you initially undercorrected the foot. It's most likely compliance with bracing problem. It could be because it's a complex clubfoot, and they actually differentiate between a normal idiopathic clubfoot and a complex clubfoot, which is not syndromic, it's not neurological, but it's different. And how it's different is like this. So this is a photograph of a complex clubfoot, and I should have given you a sideways one as well. But they typically have a short, fat, square foot. If you can see it there, this looks like a little block, and this hyperextended big toe. And if you turn the foot around, you will see that their medial crease is transverse, like that. So it's not like the normal one's more just in the medial side. Theirs is like the whole foot. It's almost more like it's a midfoot cavus, as opposed to a true sort of like cavus varus or typical clubfoot that we get. They are very difficult to correct because they are short. The feet themselves are difficult to manipulate, and they're just like inherently harder. So that's something to look out for. If you see that hyperextended big toe and the short fat foot, be prepared for a long journey. Then it could be because there's an underlying neurological abnormality that you didn't pick up. So you must examine the patient. So it's happened to me once or twice where a kid comes back and we can't figure it out, and the parents are like, no, they're wearing the braces. What is it? What is it? And then you examine it, and they've got either asymmetrical reflexes, no reflexes, brisk reflexes, and then there's some funny thing going on in the spinal cord. So the strategies for managing a recurrent clubfoot start off with repeat casting, and you should always start with a repeat casting if you can. Realistically, it also becomes difficult when they get older. They kick too much and need an aesthetic tailor, and for the parents traveling in and out. So it's all good and well to say, you can correct any foot for serial casting. But I think realistically, in any setting, it's not just in our setting, it's not going to work for everyone. And some parents will accept an inferior outcome, which is kind of unfair, but will accept an inferior outcome rather than having to go through serial, like 17 casts again to correct this severe clubfoot. So it's just the thing. Then the next step would be a tibialis anterior transfer. You can only really do those from the age of 2.5. Well, that's what's been described, and that's how it's prescribed. I think it's because of the ossification of your small tarsal bone, because you want to put it in the medial or the lateral cuneiform. And that works very well. And then, as the final resort for a small child's foot, for me, would be posterior release or posterior medial release. It's not a nice operation. We get there now, but this is just tib and transfer. So you see it moves from its insertion into the navicular to the outer side of the foot. So like I said, either the medial or the lateral. I prefer the lateral actually, but the lateral. And it works very well, and it restores the muscle balance, and the recurrence rates almost zero following that. So same as with the percutaneous sternotomies, I would rather do a tib and transfer than not do it. Again, it's the mortality or the morbidity is minimal. It acts as an internal brace, which means that after your TAT, you can say goodbye to the Dennis Brown boots, which makes everyone's lives easier. And it just really works well. So it's a surgery that I'll be quite generous with. But we still, unfortunately, do quite a lot of soft tissue releases. So I'm briefly going to go through the steps of this because you're not going to remember it anyway. And we also go through it in the cadaver foot workshop I do. But the steps for the posterior lateral release is the Achilles, of course, then your posterior ankle and subtalar joint capsules. So those are the two. And they're hard to find in the clubfoot. They're right next to each other, or they're almost overlapping because of the equines. So not easy. And what's also difficult about these surgeries is that the tarsal bones are cartilaginous. So you can't, it's very easy to accidentally cut with your blade into the bone instead of into the joint and so on. These are not simple surgery. Then it's very important to release the posterior lateral tether, and that is the peroneal sheath, the posterior talofibular and tibiotalar ligament, and the calcaneofibular ligament. Because without that, and it's difficult to describe this over Zoom or to demonstrate it. I try using my hands, but it obviously doesn't work. The calcaneus is internally rotated in the sort of in the ankle mortise, or the talus and the calcaneus is internally rotated in the mortise. You can't externally rotate them unless you untether them from the fibula, because otherwise that will act as a check rein for the external rotation. So that's a critical step, and I think it's often neglected because it's like tricky to find. It's quite small, end up cutting off the fibula. Yeah, this is not nice surgery. I much prefer the casting. Anyway, so I hammer on about this because it's important and it's neglected. Yeah, there's some pictures. Nice. This is from the book. The book is called Lovell and Winters. It's on the shelf at Maitland. You should ever want it. And there's also a copy in the library. Okay. There's some more pictures. Good. Then the posterior medial release is an extension of your posterior lateral release. So you start with the posterior lateral release, then you see what else. So there's this term in clubfoot surgery that they call the a la carte approach. So it's like a la carte is a menu in French. basically say you have on your menu a lot of procedures that you can do. You do what you have to do, basically. If you don't need a plantar fascia release, don't do it. If you don't need to release the calcaneocular joint, don't do it. You know, it's all there for you to choose from, but you do what is necessary to correct the foot. So the PMR is a radical soft tissue release operation. It's very destructive. Patients get stiff, painful feet, often overcorrected, and then get these severe, like, because you cut, if you do a circumferential release of the ankle and the subtalar joint, you cut your deltoid ligament. So then they get this terrible ankle valgus. It's not like walking on the medial malleoli. I've seen a few of those. It's terrible. So, I mean, it should be done with caution. But in syndromic feet, it's often all we can do. So the severe orthorhombic patients, myelomeningocele often have your tibial dysplasias. If you are keeping the foot, then quite often they have a very severe clubfoot with like tarsal coalitions and all kinds of things. So those ones obviously need more aggressive surgery. So this is just everything that you cut when you go. So circumferential release of the ankle on the subtalar joint. They say you should spare the deep deltoid. In fact, you could try, but it's very small. Talocalcaneal ligament, what do you see? Adductalis, plantar fascia, spring ligament, talonavicular capsule, calcaneal cuboid capsule. So now your whole hind foot's been released, and it's all going to scar up and become stiff. So even after your successful treatment, if you use Ponseti or whatever, you often have a residual deformity. The most common one that's undercorrected by the Ponseti method is the forefoot adductus. It's basically metatarsus adductus. It looks like a bean-shaped foot. So for that, you can do a double tarsal osteotomy, which I'll show you now. And then if you have this dorsal bunion, and that's just because of residual cavus, and you would address that like you would any other cavus. So either do a plantar flexion dorsiflexion osteotomy of the first ray or the whole midfoot with your plantar fascia removal. So neglected clubfoot is also a little bit of a tricky one. And I think I never did see the patient, but we've got one at Maitland now that probably looks like that, which is got arthrogryposis. Just by the by, if you do correct these, this bump goes away over time. So you don't have to excise it, but sometimes you want to just because your foot looks so nice and then you've got this big bump. But this is what it can look like. And these patients walk and they walk fine. I mean, they're pain-free, but I don't think this is a very sustainable situation in terms of late onset pain, arthritis, shoe wearing, you know, everything else like that. So for the neglected, the late presenting clubfoot, we always start with Ponseti. We think about some soft tissue releases, if they start like that. If it's more than 6 years, in my mind, the Ponseti doesn't, soft tissue releases and Ponseti doesn't work. The tarsal bones are deformed, and you're not relying on soft, pliable, cartilaginous bones to correct. Yeah, I mean, it's proper bones. So a TSF correction can work fairly well at this age. A combination of osteotomies and fusions, but usually these will have a poorer outcome, stiffer foot, than if you had a successful Ponseti treatment at birth. Yeah, so that's the doctor's article. And in this case, they found that excellent correction. The feet weren't any more stiff than they were before treatment, which is fair enough because they usually do come with quite a stiffness. But they did get recurrence of their forefoot adductors. And this is just a little girl that I've recently done with one of our colleagues. And she, I don't know what the underlying diagnosis is, like the developmental delay, fecal alcohol syndrome, parts like that. And she had this sort of persistent recurrent clubfoot. She's already had PMRs. So we did a little frame for her, and she actually came out quite well. You see how nice and flat and dorsiflex she is on that side. So that works well. So then for the older kids, you can do some osteotomies and fusions. See, here's a la carte again. So just do what you have to do, basically, to get a plantar foot. Spare joints if you can. A neurological clubfoot. So I often get very severe neglected quite a various feet in CPs. And for them, the triple arthrodesis works extremely well. And on your other neuromuscular conditions like arthrogryposis, etc., also. But give an adequate surgical dose. I think for these very stiff neurological severe club feet, the soft tissue release isn't going to really get you anywhere. So do what you have to do to get it party broken. Okay, that's clubfoot. We did well. We're going to be finished just after 9. Okay, so this is a cavus foot. So let me see who I got here. Peter Botha.
Anria.
Hi, Peter. How are you?
I mean, so?
Okay. Cool. Just look at this guy's feet and just tell me a little bit what you think about it. What am I doing here? How is that going to affect your approach to this child? And anything else that you think might be of importance?
Yes. It's clinical pictures looking at from the hind foot views. Ideally, you're looking at whether the hind foot is correctable or not using a Coleman block test here. So first ray or second ray is off, and then the lateral aspect of the third and fourth are on the block. And you're seeing whether or not that it actually reduces into neutral or better yet into a valgus position. If it's and then you assess whether it's hind foot or forefoot driven from that.
What do you think?
He's also got surgical scars there. So I take it that previous operations to correct this deformity. I think in that position doesn't look like it. I think it's particularly fixed. It doesn't, or maybe even neutral, but I don't think so. I think it's still in varus.
How's this going to change your approach? How's it going to change?
I mean, it kind of tells you whether it's flexible or stiff in a way, and then whether or not you can do soft tissue with certain body procedures, or will you need to have to do some fusions, I guess, in terms of management.
Okay, so to be more specific then, if it didn't correct, so let's say this is a stock standard varus foot, and it didn't, you're saying it's not correcting. What exactly will you do for this patient? What will you offer him?
I would offer him a calcaneal osteotomy. Then I would do a lateralizing calcaneal osteotomy with also soft tissue procedures as well. Where you do, I think it was a peroneal longus to peroneus brevis. You can also do a plantar fascia release if need be. And then you can also do a dorsal closing osteotomy, I think, of either the proximal metatarsal, or you can do it from the medial cuneiform as well to close down your midfoot. That could be another,
yeah. No, so that's excellent. So you be specific. I don't like it when guys talk about soft tissue or bony. It's like, you're like almost a qualified orthopedic surgeon. You're not going to consent the patient for a bony procedure. Tell me what you're going to do. Because bony in itself isn't necessarily the correct answer. So yes, you're absolutely right. I must say, I thought he did correct. He's certainly more varus in the left side of the picture than on the right. But so he didn't correct fully, but he did correct in neutral. Anyway, I still did a calcaneal osteotomy and things for him. And interesting, he's not a neurological well, he is, but not. He's just been very unlucky. So he had a previous open fracture where he must have ruptured his posterior tibial artery. And then he had another open fracture where he ruptured his tibialis anterior or his anterior tibial artery, which luckily we fixed. But he lost quite a lot of soft tissue in the process, and he's completely unbalanced. He's got a drop foot, but no evert. It's a little bit complicated. But yes, that's correct. Thank you. Okay, so the varus foot is not strictly a diagnosis. It's a description of a deformity, because your diagnosis will be Charcot-Marie-Tooth syndrome or Charcot-Marie-Tooth disease or something like that. The varus foot is almost like a symptom more than a diagnosis. 2/3 have an underlying neurological disorder, of which 50% will be CMT. And other ones will be, like, I don't know, some of your spinal conditions or peripheral nerve injuries, etc. So for the purpose of, for diagnostic purposes, we divide them into bilateral. And there's a long list of things that it can be. So it's all neurological, or muscular, of course. It can also be tethering from the muscles and so on, but the deformity is basically the same in the end. Yeah. So here you go, there's your long list. It's also in the book. Okay, so clinical features will be instability of gait and frequent falls. And often they'll present with frequent ankle sprains more than, they didn't really notice the deformity, but they noticed that they keep spraining their ankle. They might have callosities under the metatarsal heads, the base of the fifth metatarsal and the PRJs due to clawing. Medial longitudinal arches elevated, of course, is cavus, lateral borders convex, heels and bearers. You see atrophy of the intrinsic muscles. So we used to call it, or we call it a stalk leg because of the way the feet are, and then these thin little calves, and then the normal sort of sized knees and thighs. Then you can see that looks a little bit like a stalk. Yes. So what you're looking out for in your history would be a family history, of course. Also, upper limb symptoms, progressive disability, reflexes. You check them, are they there or they're not? Sensation, spinal abnormalities, and upper limb features. So in CMT, if it's more advanced, they have wasting of the intrinsics in their hands as well. And then just for those who didn't spot this, that is the syringomyelia. It often happens post-traumatically in the spinal cord, but sometimes people are born with it, and it gives you upper motor neuron type of disorder. So the pathoanatomy of the cavalieri's foot is a little bit complicated. So it usually starts with intrinsic wasting. So we know from the hand, if you get intrinsic wasting, you get clawing. So now if you have clawing of your foot, you have hyperextension of your first metatarsophalangeal joint. So that then activates the windlass mechanism. Because if you examine the flat foot or whatnot, you extend the big toe, you get the arch reconstituting. It's a windlass mechanism, you're tensioning the plantar fascia. So that happens. Now you're getting this high arch. Then it becomes contracted, both the plantar fascia and the intrinsic muscles, and that gives you the clawing and the cavus. But that doesn't necessarily explain the varus. So what happens though is because you get this progressive plantar flexion of the first metatarsal, it's almost pronating the forefoot. And then in order to sort of to compensate for that, so that you don't, so that you're still sort of wavering on your foot, your heel turns into varus. So the hindfoot varus is very much driven by the forefoot pronation. And that's another reason why we do the Coleman block test, because we're eliminating the forefoot pronation, isn't it? So there you can see what's happening to the heel. And if it's very flexible, merely elevating the first ray may solve the problem. So that was that bit. Then there's the tibialis anterior that's weaker than peroneus longus. So a bit of a drop foot, you've got peroneus longus further plantar flexing your first metatarsal as opposed to the and that dorsiflexes the third metatarsal. Then you get weakening of peroneus brevis. So that's your evertus, and now I've got inversion, and that's opposed by tibialis posterior, so you get progressive hypervarus. And this here also explains your tendon transfers that Peter correctly said. So take the post, put it on tip ant, because tip ant's weak, the post is strong. This is causing the deformity. This weakness is causing the deformity, so that works really well. And same thing with the peroneus brevis to longus, or longus to brevis. Brevis is weak, you don't have an everter in the foot. Longus is strong, it's worsening the deformity. There we go. So it's all very logical. But the secondary problems they develop if you leave it untreated, and this is early and later, of course. So attenuation of the lateral ankle ligaments, of course, peroneal tendon tears, compensatory external tibial torsion, defunctioning of the Chopard joint, varus knee, ITB problems, and tibial stress fractures. So one really should address this. Unfortunately, the diseases are typically progressive. So CMT is a progressive condition. You don't get better. But having a plant, I mean, you can always go back and do more things. If you leave it as is, that's obviously not sustainable. So when we look at the radiology of a cavalieri's foot, we're looking at a few different angles, but most importantly would be the Meary's angle. So that one you all know well is the first metatarsal on the long axis of the talus. It should be 0. So in a severe cavus foot, this one you can see is 30 degrees. And then the calcaneal pitch should be less than 13 degrees, and it's 39. And I just want to point this out. It's like something that bugs me a little bit. When they talk about a flat top talus in clubfoot, they often take an X-ray of the clubfoot and then they see a flat top. But look at this foot. It's inverse, so the talus looks flat. And I think this flat top talus nonsense is actually just undercorrected hindfoot varus. I'm still going to do a study about it when I have time. But what you also see then is you're looking at the sinus tarsi like this, you can see through it. And that's another clear X-ray feature of hindfoot varus when you look. Okay, so diagnose and treat the pathology if you can. Blah, 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 we'll see all of that. So release contracted soft tissue, correct abnormal bony alignment, and rebalance the muscle. That's what we do. Here's the common block test again. It's just a nice picture. Okay, so for the flexible hindfoot and milder deformities, then this very severe one. I mean, 3 people just left the meeting. Did I say something offensive? Anyway.
But guys.
Eh?
No, I think it's some of the other university guys who maybe have a curfew or something.
Oh, you know, it might actually, well, no, probably not load shedding. Anyway, I'm good. Thank you, Skulk. Okay, so flexible hindfoot milder deformities, what we want to do is we want to do the same. So release the contracted tissues, rebalance the muscle, and then potentially correct the first ray. If your plantar fascia release is not enough. So this is quite a nifty procedure. This is I think I mentioned to you on Monday, but it was a study that they did. What they did is they did a percutaneous plantar fascia release only, and then guided growth of the first metatarsal with a tiny little bit. And it actually worked fairly well. I mean, it's not dramatic, but this is a mild flexible cavalieri's foot. It's not very bad at all. And it's just looking a little bit better there. All the angles are better there. So, and that AP, you can see also it's like a little bit turned in and it's not. So that's quite a nice thing to do if you want. The fixed deformities, we go big. So we do the dorsal, again, Peter had like 100% for this question, dorsiflexion osteotomy of the first ray, or the whole midfoot and a calcaneal slide or a closing wedge or a Dwyer osteotomy of the hind. And that's how that looks. So the Dwyer is just a closing wedge, but I think Brian actually also does it like that. Is we do the closing wedge and we lateralize, you get more correction because you actually can't get, there's not that much bone to take out in the calcaneals in your child. So in order to maximize your correction, you just lateralize it a little bit as well. And then this is the midfoot osteotomy for cavus, quite nifty. Very nice. So the calcanea of cavus foot, that's quite rare. So mine and Nicosia polio, which I just put in there for the sake of completeness, but it's not. But with all the anti-vaxxers in Nordic, we're going to have to start learning about polio again. But that's what you can get. It's mostly caused by static neurological injuries and this imbalance between the ankle and toe dorsiflexus and the triceps. So your triceps are not working, but your toe and ankle dorsiflexus are working. So you get that situation there. And that's usually in your L5 S1 monomeningo seals. This is called a pistol grip deformity. Who else gets a pistol grip deformity? Sufi. Yes. Anyway. Okay. Anterior release, then the transfer of tibialis anterior to calcaneus. That's called a P-body transfer. That's just to try and get you some active plantar flexion. But you don't want active plantar flexion at the expense of active dorsiflexion. So if you don't have proper power in your toe extensors, then you can't do that. Because you need something to lift it with. And then also osteoarthritis in people. Okay. Congenital vertical talus. So this is again a relatively rare condition. And the typical deformity we see is this Persian slipper deformity. So that's what a Persian slipper looks like. And that's what a CVT looks like. So people see these and they send them to the clubfoot. It's not. It's the exact opposite, basically. So it's isolated in 50%. I'm not so sure about that. Like I don't think I've ever seen an isolated CVT. It's always part of some other syndrome, very often arthrogryposis, myelomeningeal, of course, and then it's not there on my list, but your sort of fetal alcohol syndrome type of kids got spread on shoulders and everything together. So it's not something you'll sort of get in isolation. So what these kids have is a convex plantar surface, Persian slipper, the calcaneus is in the equina valgus. It is actually palpable in the sole of the foot, the forefoot's abductor. There's dorsal dislocation of the navicular on the talus, also of the cuboid on the calcaneus, and that doesn't correct with maximal plantar flexion. So when you take x-rays, and I apologize, I actually have like new x-rays of a kid from 2 weeks ago, but I didn't have time to download them this time. So these are old grainy x-rays, but they still show you what you want to see. So for the diagnosis or the confirmation of your diagnosis of the CVT, you take an x-ray of the foot in maximal dorsiflexion and maximal plantar flexion. Because what you want to see is you want to see if the navicular reduces onto the talus in maximal plantar flexion. So not really, because the navicular is meant to be there, you see. So this is the maximal dorsiflexion. You can see that midfoot break, that Persian slipper somewhere there on the x-ray. And with the maximum dorsiflexion, the talus for plantar flexion, it doesn't reduce. Okay. So the congenital oblique talus, is not a very clearly defined entity. And in my mind, it's sort of part of the spectrum of the severe flat foot. Because if you look at the x-ray of a severe flat foot, the talus is also plantar flexed. And there's often also an Achilles contractor. So especially in my CV patients, I see that a lot. So no, I don't really think it's a thing that needs, the only treatment that probably needs is an Achilles tenotomy or a gastrops or something. But the pathoanatomy is that they have contracted anterolateral posterior structures. So the Achilles, the lateral structures, and the anterior structures are all contracted. But this wedge-shaped navicular attenuation of the spring ligament, and then external rotation, eversion of the calcaneus, hyperplasia of this sustentaculum, and the contracted dorsal talonavicular capsule. So initial treatment for these kids would be reverse Ponseti. So that's it's literally the exact opposite of what you would do in Ponseti. So you end up with a foot that looks like a clubfoot. That's kind of your goal, because you want to correct everything except the equinus with your casting. So you want to get plantar flexion, adduction, and cavus basically before you do that. And then once you've managed to get the foot in a reasonably corrected position, you can see what they do there is you do your percutaneous Achilles tenotomy and you pin the talonavicular joint. Usually or very often, even though you have like quite a nice cast correction, you still have to do a little mini open reduction of the talonavicular joint. So you can do a small incision, open the joint, reduce it, and pin it. It works fine. And then you maintain them afterwards in casts and then in ankle foot orthosis. There's no, that I'm aware of, there's no equivalent to the Dennis Brown boots for CVT. Because I think then you'd have to have your feet like this. That's coming in. Okay, so this is the guy, Matthew Dobbs. He's an American guy. He always wears a bow tie. He's like quite eccentric, but he's very, very good. And so he popularized this reverse Ponseti business for the CVTs. Works very well because historically if you just do extensive soft tissue releases and so on, it was just not great. I mean, the feet didn't come out very nicely. So this looks better. So there's all your options, things you can do if your casting doesn't work, or if they come to you late, or if they're from PE and you can't cast them because it's not possible, then you can do a proper operation and so on. So guys, I don't really have many cases. It's difficult with the feet. Let's take Francis.
Hello.
Hi, Francis. How's it?
Good, thanks.
Cool, cool. Just look at these feet. Tell me what you think. Tell me what your options are. This boy is 10 and he can't wear shoes. Sorry, unfortunately, I don't have clinical pictures for you.
Okay, sure. All right. So APs of both feet, both with some deformity, worse on the left. I'll focus on the left first. Just starting at the hind foot, there's a decreased talar calcaneal or kite's angle. And there is also forefoot adductus. And the metatarsals also seem deformed with sort of bowing in a medial direction. And yeah, the talar head, there's talar navicular uncovering as well. Then if I'm comparing that to the right, so there's a better kite's angle. It looks possibly normal. Still talar navicular uncovering about 50%. It's a bit more than you would like to see. Still some forefoot abnormality with adductus. He does still have his growth plates open, and then yeah, the sort of the cuneiforms, they just look a little bit small and underdeveloped, not quite the normal shape. So I'm going to hazard that he possibly has bilateral club feet. Left was worse.
So he's never had clubfoot.
Oh, okay. So yeah, I mean, you were just talking
Always
about.
just look like this, and now it's bad because he's 10. He wants to wear shoes and he can't.
Oh, okay. So just for just metatarsus adductus.
Well, yes, that's
Yeah.
That's quite accurate. Yes, so that's what he has. But one thing you pointed out, and you're absolutely right, is that there is some uncovering of his talus and a possible hindfoot deformity.
Mm.
So have you heard of a condition called skew foot?
Oh yes, yeah. Okay.
I saw him the first time and I saw his x-rays. I also thought he was a skew foot. But the more I looked at him, the more I realized his hindfoot was actually okay. So a skew foot is like a combination of hindfoot valgus, so basically a planar valgus foot at the back, but then adductus at the front. So it's like an S-shaped deformity, and then you do combination surgery. So you do flat foot surgery for the heel, but surgery for metatarsus adductus for the midfoot. So Francis, what surgical options, or what would you offer this child, considering his age and his predominant deformity?
Yeah, so I would like to know about the strength of his tendons, particularly tib and his peronei, because that might come into it. But ultimately,
it's not a cadaverous foot.
yeah, no, but ultimately he does have a bony deformity. So I would consider a midfoot, he's still a bit young, but so midfoot opening, medial opening wedge osteotomy. And as you said,
50%. So no, it's fine. You do a medial opening wedge and a lateral closing. But
okay.
I'll show you.
Right.
I'll show you some more.
bigger
Yeah,
correction. Okay.
Well done. This is a metatarsus adductus. So the most common congenital foot deformity. So it's slightly more than clubfoot. Clubfoot is 1 in 1,000, supposedly. higher incidence in twins. Here we think it may be a positional thing. There's this supposed association with torticollis and what's the other packaging disorders. Yeah, but I don't know, not necessarily. Anyway, the anatomical abnormality is a trapezoid medial shape, trapezoid shaped medial cuneiform in the more resistant types. Let's just see. Yeah, sort of. Anyway, there's a classification, of course. It's mild, moderate, and severe, and it all has to do with where the heel bisect the line is. So we know normal is between the second and third toe, and then it moves progressively more lateral as it gets worse. And then you can also look at its flexibility. So 90% will probably correct spontaneously by themselves, or remain asymptomatic for life. Only 10% require treatment. So if they come early and it's quite severe, then I would recommend casting. So you can, because it's not clubfoot, you could correct this deformity with a cast very easily, like in 2 casts. And then they're straight, and then it's done. Because otherwise you're going to have persistent follow-ups. So Dr. the toes are still turning in. What must I do? Does it need special shoes? So in the more severe ones, just cast them if you can. And then we do use some corrective shoes post-casting. So the shoes we use is called a reverse last shoe. You can buy very expensive ones from the orthotist, or you can just take your normal shoes and put them on the other feet. We call those banana shoes. And if you wear rigid shoes, or like slightly more rigid shoes, you know, like those little the leather shoes that the babies wear, you wear those, and that works quite well. So surgery would only be indicated for symptomatic stiff feet, and for instance, if you physically cannot wear shoes. So we do it when there's pain of the base of the fifth metatarsal, very often difficulty in shoeing and cosmesis. And my preferred treatment for this is a double tarsal osteotomy. So what you basically do is you take out a wedge out of the cuboid, and then you put that same wedge into the medial cuneiform. And that's the correction that you get there. There is another technique described I've never done, but it's multiple metatarsal osteotomy. So you do like many incisions, and you can use like a burr or a tiny saw. You just basically do a straight osteotomy of all the metatarsals and turn them straight. But like I said, I haven't done that. The results were very interesting. Okay, this is the last bit. Fidelis. Cool. No, there is.
Yeah, hi, Anria.
Hi, Fidelis. Have a look at these clinical X-rays and tell me what's the problem and how would you address this?
Okay, looking at the picture on the right, looking from behind the patient, you can see that the hind foot is in valgus, and I think you can also appreciate too many toes sign from the back. And then on the right side, it's the patient is standing on their toes, and you can see that there is correction of the hind foot valgus on the left side.
On both sides.
Sorry, come again?
No, I said both feet.
Yeah, so I think the foot on the left side, it can sit on an angle, but I can confidently say that on the right side, I think it's correcting. I think there's less correction on the left side, I think.
This patient is symptomatic, so she came to the hospital she gets tired, her feet pain, and she gets tired, she's got pain over sinus tarsi, and she wears out her shoes very quickly. So what can you offer this young lady?
Yeah, so I think my first option will be to try with conservative management, see if there's improvement in the symptoms, which is going to include fitting of sore orthotics to support the medial arch, and then if there is no improvement with conservative management, then probably we can consider offering surgery. From my understanding, this is because of insufficiency of tib posts causing this flat feet. So in terms of surgical options, you can, depending with if it's a depending if it's flexible flat hind foot or it's a fixed hind foot. If it's a flexible hind foot, I think I would consider a soft tissue procedure. I think maybe like a tib and transfer to support to sort of correct the tib post insufficiency. Then if it's if fixed deformity, then you can consider a bony procedure.
Okay, not quite. There's a big difference between pediatric flat foot and adult flat foot, but that's okay. You are absolutely right. It's a flexible flat foot. Start with conservative management, and then we move on. Dane, what would you offer this patient, considering that it is a flexible flat foot that's symptomatic and the insoles didn't work? Down there.
Sorry, can you hear me now?
Yes.
Okay, so because it's a flexible flat foot, we're not worried about a coalition in this case. The majority of these cases will resolve with age. So as Fidela said, you can certainly start with conservative orthotics if they help, otherwise symptomatic treatment in terms of analgesia. Ideally, you would like to see them through to skeletal maturity before you consider bony procedures. As I said, most of them do resolve spontaneously. If not, and she's very symptomatic and we're going to do something, you can consider Achilles tendon lengthening, or I believe a calcaneus lengthening, like an Evans type procedure.
Yeah, good. So you only lengthen the Achilles if it is short. So you just need to confirm that. But yeah, so the Evans procedure works extremely well for this. And also then the arthroresis. So we'll go for that now. So what we basically have is we've got external rotation of the calcaneus under the talus, abduction of the forefoot around the navicular, hindfoot valgus, flattened arch, and the too many toes sign. So if the patient presents to you with a flat foot, because very often they come to you just because of the way it looks. But sometimes it is actually quite symptomatic. So ask about the pain. Where is the pain? So typical pain associated with severe flat foot would be sinus tarsi pain. So sort of like circumferential around the dorsolateral aspect of the foot. And then sometimes they get subfibular impingement. And then also if the talar head, if there's a very bad flat foot, they can get velocities under the talar navicular joint, basically, because it's the weight bearing on it. They get foot fatigue, they can't wear the shoes properly, frequent sprains, but that's more indicative of a tarsal coalition, which we're actually not discussing in this meeting. So then you see, is it flexible, is the gastroc short? There's a couple of angles we can measure again. So I must say, typically, I don't take x-rays unless I'm worried about some underlying like a dorsal coalition or an accessory navicular or something like that. But again, we measure Mary's angle, calcaneal pitch, then the talus first metatarsal angle, because in the severely abducted forefoot, obviously that would be increased, and then also on the AP, the talocalcaneal angle, if we can. So conservative in orthotics, and then there's 2 surgical procedures for the flexible flat foot that I would recommend, and that would be your arthroresis, and then also lateral column lengthening. So the more extreme surgeries like the subtalar fusions, or even in some very severe cases, the triple arthrodesis, are typically done in stiff flat feet, which are pathological flat feet due to something else. So for the flexible flat foot, that's never that shouldn't really be on your menu. So arthroresis is a screw that gets put into the sinus tarsi and it blocks eversion of the heel, and that's how it corrects the flat foot and the arch. Works well. The perfect timing is basically sort of between 9 and 11 years of age. It almost has a similar effect as guided growth, in the sense that because the bones are growing and they're placed in the correct position or corrected position, they develop normally. So once you take out the screw at skeletal maturity, the correction is maintained. So it's quick, it's easy. They're back on their feet 2 weeks after the operation. It's not 100% guaranteed. It's not very powerful, but it works for your milder flat feet if there isn't a lot of forefoot abduction. But if there is a lot of forefoot abduction, then you want to basically rotate the forefoot back around the head of the talus. Now, flat foot is like the opposite of the flat foot. So now you want to turn it the other way. And this is where the Evans procedure, or the lateral column lengthening, comes in. And this is just a diagram illustrating how it works. So you go between the anterior and the middle facet of the subtalar joint, about 2 centimeters posterior to your calcaneal cuboid joint. You cut in that direction and you put a piece of bone graft in there. So iliac's the best. There are actually some companies now that make little peak cages and so on that you can put in there. You just use iliac breast and see what happens there. And you can see this intra-op as you do the correction. Just look how beautifully the foot rotates back around the talus, because you're swinging it around like that, and because you're lengthening calcaneus, you're basically tightening up the plantar structure, so your plantar fascia and your abductor analysis and so forth, and that restores the arch as well. So this is a very nice operation. Complications though is graft migration. So because that little piece of bone is under quite a lot of pressure there in the calcaneus, it can pop out into the sinus tarsi, which is most unfortunate because it causes pain, and obviously you lose your correction. Then the subluxation of the calcaneal cuboid joint is also a problem. It can, to a large degree, be prevented by pinning the CC joint before you actually open up the osteotomy. So that's just a few things, and then all the other usual ones. And I think this is actually the last slide. This is just like a little by the way. There's an accessory navicular. It's a common cause of flexible flat feet. It was often associated, and you can spot them because they'll have the flat feet, and then they have this very prominent bump with a callus on it over the navicular with the flat foot. And you know, okay, that's probably it. And the reason there's a flat foot, and this is in this case fidelis, it actually is because of the tibialis posterior is attenuated because of its insertion by basically being moved more proximal. So they can usually come for complaining of pain over the accessory navicular, and that's because of the abnormal movement in the, it's like a synesmosis basically. So if you do an MRI, you can see there's this like connection, a cartilaginous connection between the accessory navicular and the actual navicular, and there's a lot of edema in the bone around the little synesmosis. So there is pain because of this abnormal movement there. It's like a little bit of it's like an osteochromiale. You know, they also get pain. It's not normal. They get that. So cutting out the navicular solves that problem. But even if you tighten up or augment the tip post, that doesn't actually correct the factor. So if you do treat it, you have to combine it either with the Evans or an arthroresis as well. But like I think of every 50 flat feet I see, I operate one. It's really you have to be very sure that the indication is correct, because really most people can live quite comfortably with their flat feet for the rest of their life without ever having an operation. Okay, I'm going to stop sharing. Okay, any questions?
Sorry, Dr. Horn, just one question. For the congenital vertical talus, after you do sit, is there any, benefit in doing a tib and transfer onto the talar neck to sort of maintain that position, or is the wire enough after taking it out?
It's not really a thing. No, it's not described. I mean, it's probably not a bad idea. I suppose if we do more, if we see more, one could have tried that. But what one does is, you have sort of lengthened the tibialis anterior by either surgically or with your casting. So it's not as tight, but it's not really a thing. Good thought. Anyone else?
Sorry, I've got one question, Doc. So for your flat foot, do you routinely consider the cotton osteotomy as well, or you?
No. So thank you very much for pointing that out. I didn't mention that. So that would be in the stiffer flat foot, probably. Where once you correct the hind foot, the forefoot is still supinated. So that's sort of a decision that you make when you examine the patient. So you sort of pull the hind foot. Thank you actually for mentioning it. I must add that to my lecture. But yeah, when you correct the hind foot to varus, then you see what's happening to the forefoot. And if it's still supinated. I frequently do it, but not always, not routinely, no.
Oh, all right. No, thank you, Doc.
Good question. Yeah.
Yeah, so on top of the flat foot, do you also consider like a spring ligament reconstruction or just tightening on like a flexible or not? Or is it just more adults?
Like it's discussed, but I don't really know. It's not common practice to do spring ligament reconstruction for a flat foot. But I have read about it or seen it mentioned in some books and articles. Maybe we should start doing it. Okay then. Well, thank you very much everybody for sticking around. Yeah, I'll see you guys around. Have a good night.
Thank you. Cheers.